Thank you, Marianne. We're queuing up the video now. Amy, I think you're going to have to relaunch. The video is not launching. I apologize. I think we had a YouTube video technical challenge, Mark. Maybe we could try to relaunch the video one more time. If that doesn't work, we can certainly go into the other method. Yeah, Amy is saying that the YouTube video is not playing, Mark, and you may be on mute. So maybe we'll just go into the slide deck and we can go through the process.
Let's go into the slide deck right now. Michelle, if you'll go, oh, here we go. I think we've got the YouTube version pulled up. So
Wonderful. Thank you. So we're going to now queue up the presentation. I'll give just a brief background on Vita Health. I'm Craig Foster. I'm the Senior Vice President of National Sales for Vita Health. I've been involved in working with Mark Chappell and Marianne Fazan of the Dallas War Business Group for many years and really enjoy working with the members. Can we bring up the presentation deck and then we'll just get started?
Yeah, we're getting that deck pulled up for you now, Craig. Apologies for the confusion here. I think we were just having a little difficulty accessing the YouTube link, but the slide deck is coming up here shortly. So give us just a minute to queue that up.
Great. Thank you, Mark. Perfect. Perfect. So Vita Health has been it was founded in 2014, and it was for the purpose of helping patients and your employees manage both the physical and mental health needs they have. Next slide, please. And the beauty of Vita, in my mind, is that we've really grown significantly to the needs of the marketplace, certainly in a COVID marketplace where 76% of employers are looking to expand access to telehealth and virtual care. So Vita has grown as a virtual care, virtual therapeutic provider to over 900 providers licensed across 50 states to support the extended needs of your populations. We have significant benefits in the fact that we have high customer service as evidenced by a 74 net promoter score. We have 100% retention of our software as a service model that we've retained since 2014, and we've grown to over 500 employers. I think it's important to understand that we've also experienced significant growth in the lives of your membership and your employees to almost 2 million members and over 400,000 people with diabetes. Next slide, please. So just a short snippet of some of our marquee clients, which are represented by large provider groups, payers, as well as enterprise employers. And many of these in the Fortune 50 that have literally employees and patients in all 50 states. It was incumbent upon us to be able to scale to the needs of these large employers. Next slide. And a key issue for those employers, as we understood it, was we really wanted to move away from transactional care. We wanted to move into a collaborative care model like an ACO. And when we do that in an integrated delivery system, as Vita provides, what we really do is we learn that we can then treat in tandem both the chronic and the mental health needs of your members and patients and employees. And this really then supports the expansion that many of you are looking to experience and improve within your own populations. And so we've done that, and by providing better access, lower cost, and better quality outcome, Vita has lowered total healthcare costs across our echelon of customers. Next slide. So Vita is quite different. When you think about an integrated delivery system, what you think about is value-based care. You think about providers that work in tandem to support the mental and physical needs of your population. And so at Vita, we provide 3 stacks of modularity, meaning we will provide support services for the wellness and preventive and population health needs of your membership, which really provide preventative care and keep them out of the high-cost claimant pool. And then within the chronic condition realm, we have 6 best-in-class chronic condition management solutions that support hyperlipidemia, hypertension, both pre and post diabetes, asthma, and COPD. And we're constantly evaluating other solutions in the market, and we'll be bringing on additional chronic condition capabilities in 2021. And then we also, as I mentioned earlier, we don't treat in a vacuum or in a silo. And so we provide additional services and capabilities around cognitive behavioral therapy for those that are diagnosed with anxiety, depression. And then we have subclinical capabilities around stress and resilience and sleep health, which may not have clinical, therapeutic requirements, but where people definitely have common co-occurring conditions within the mental and the physical health needs they have. And to be able to simplify their lives and provide this in one integrated delivery system really simplifies and brings a lot of relief to your members. Next slide, please. So our platform is built around the notion that treating the body and the mind together brings greater results. And our book of business suggests, and this is just one of many slides that are available, that those folks that are looking to remove weight or to reduce their weight are getting more than 2 times better outcome if we're also able to treat and work with them on their mental health needs, and in this instance, cognitive behavioral therapy. And so in this slide, we're showing how the reduction of weight of our book of business membership is also in alignment with those purple triangles, which is how we're introducing and in fact improving their mental health capacity for anxiety, stress, and depression through cognitive behavioral therapy. Next slide. So in conclusion, I just wanted to share some outcomes, but before I share the outcomes, I want to just again talk about sustainability. One of the bigger challenges that we find when we deal with chronic conditions or mental health conditions either is that they actually have to be treated in tandem, and that part of the problem of these solutions historically has simply been that whether you believe the depression and the anxiety and the stress is what creates those unhealthy habits that result in chronic conditions, or whether you think it's the chronic conditions and the poor quality of life and standards that are creating depression, anxiety, and stress, what we want to say is that by looking at these not in a vacuum, not transactionally, but collaboratively in an integrated delivery system, creates simplicity and better outcome for your members. And that's what breaks an unsustainable cycle of people constantly gaining and losing weight, gaining or reducing A1C and blood sugar. And so these are what drive the outcome for Vita, where we see best-in-class outcomes across our book of business. And so this just gives us the fertile ground to have future conversations, and we appreciate the time with you today.
That's great. Thank you very much, Craig, for telling us about Vita. And also thank you for sponsoring this forum. We appreciate that. So let's launch right into our very first session. It's called The High Cost of Low Value Care, Identifying and Eliminating the Culprits. Now, there's lots of low value care out there, and it always adds cost to your healthcare dollars anyway. So, but there are ways to identify some of the culprits and also to eliminate it. And I hope this will be very helpful for the employers in this room on how to do this. We have two speakers that I'm so pleased to introduce. Paul Fronston is the first speaker. He is the director of the Health Research and Educational Program at the Employee Benefits Research Institute. That's a private, nonprofit, nonpartisan organization committed to original public policy research and education on economic security and employee benefits. He oversees EBRI's Center for Research on Health Benefits Innovation and has been with the organization since 1993. His research interests focus on trends in employer-sponsored health benefits, public policy, consumer-driven health benefits, HSAs, private health insurance exchanges, workplace wellness programs, retiree health benefits, and public opinion about health benefits and healthcare. Paul's focus today in the first half hour will be on a new study that EBRI has done. It's called Do People Choose Wisely After Satisfying Health Plan Deductibles? Evidence from the Use of Low-Value Health Services. Immediately following Paul's presentation, we were pleased to invite and recognize Gary Strelke. He's the Wellbeing Navigator at Steelcase Incorporated. That's a 108-year-old global company that offers a comprehensive portfolio of architecture, furniture, and technology products and services designed to unlock human promise and support social, economic, and environmental sustainability. In fact, Steelcase was recognized this year as one of the 2020 world's most admired companies in the home equipment and furnishings industry. And as the Wellbeing Navigator, Gary helps Steelcase's 12,000 employees improve all dimensions of their well-being by connecting employees with a broad selection of vendors and services that will help them improve aspects of their physical, emotional, and social health. Gary has worked in the corporate wellness field for 18 years in a variety of roles, including exercise physiology, corporate wellness management, fitness management, neuroscience, and mental health. So we'll start with Paul. Thank you for being part of this, and I'm really eager to hear about this new study on low-value care, an interesting twist, I understand.
Thanks, Marianne. You put together a terrific program this week. I'm very honored to be part of it. Thank you for including me. As you could all see from the slides, I'm going to talk about deductibles and low-valued healthcare services. I have a lot to say about deductibles, and there's no way for me to get through it all in 90 minutes. So I'm going to give you a brief overview. I think I get the distinct honor of being the most popular person at cocktail hours because everybody wants to talk about deductibles. Just a quick word about EBRI. We're a nonpartisan organization. We've been around since 1978. We're a membership organization supported mostly by member dues. We have a very diverse group of members. Despite being in Washington, D.C., we don't lobby. We don't advocate on positions. We're strictly a nonpartisan, unbiased resource for our members, for public policymakers, and for the media. We focus mostly on retirement and health and sometimes financial well-being. And if anyone ever wants to learn more about EBRI, please reach out to me. As you'll see on the next slide, I think one of the, aside from this year when we saw this major ramp up in use of telemedicine visits, perhaps one of the strongest trends in health benefits has been the movement to high deductibles. And if we use the definition of a high deductible that goes along with an HSA eligible health plan, what you see here is that as of 2018, 46% of the privately insured population under age 65 was in a high deductible health plan. A little less than half of those people, that's the orange portion of the bar on top, were in a high deductible plan that came with an account, either an HSA or an HRA, and a little bit more than half, that's the blue portion underneath, were in a high deductible plan that didn't come with an account. I think the number of people in a high deductible that have a high deductible is actually larger than the 46%. And I would note we don't have the 2019 data yet. I think it's higher than the 46% because this doesn't count all those deductibles that are below the HSA eligible deductible threshold. And depending upon your definition of what truly is a high deductible, all of those deductibles that might just be below it, maybe $1,000 deductibles or $1,200 deductibles, they're not even counted here. So you see the strong trend towards deductibles. And there's a lot, many years ago, 10 years ago, we didn't know about deductibles. And real quickly on the next slide, what you'll see is on the HSA side of things, there's been a tremendous growth in the assets in these accounts, as well as a number of accounts. As of the end of, as of this year, about $77 billion in these accounts, and about 29 million accounts out there. Next slide, please. One of the things we know about, next slide, please. One of the things we know about people in high deductibles is that they behave differently than people not in high deductibles. And this, a lot of data here on this slide, but the basic takeaway is that people in high deductible health plans are more likely to do a number of different things when it comes to being cost conscious. They're more likely to check whether their plan will cover their care or medication, more likely to check prices, more likely to be interested in quality ratings, more likely to talk about treatment options with their doctor, whether it's for prescription or medical cost, more likely to ask for a generic drug instead of a brand name, and even a little bit more likely to use an online tracking tool, as well as develop a budget for their healthcare expenses. Basically, across the board to various degrees, people in high deductible plans are more engaged in their healthcare. But that's not the end of the story. And go on to the next slide, please. What we've been interested in EBRI for many years is what impact do deductibles have on use of care? And in the study I want to share with you today, we looked at the impact that deductibles have on use of low-valued services once people meet their deductible. And there's been a lot of attention on low-value services over the years. There's the Choosing Wisely campaign, which I'll talk about more in a second. What we know about low-valued services is that oftentimes there are little clinical value, little clinical benefit, and they can even be harmful. Under low or no patient cost sharing, there's this potential for moral hazard, which means that people will use care that they don't need. Once people reach their deductible, their cost sharing goes to zero or it's low. It may be a $10 or $20 copayment. It may be 10% or 20% coinsurance. So the full impact of the deductible is basically gone at that point, and people may use healthcare differently. So we focused on, in our study, we focused on data on 5 low-valued services: imaging for low back pain, imaging for uncomplicated headache, pre-op testing for low-risk surgeries. In this case, we looked at hernia repair, vitamin D testing, and PSA testing. In addition to those services, we looked at the various cancer screenings that we typically look at, breast cancer screening, cervical cancer screening, colorectal cancer screening. And basically, we studied the effect of having reached a deductible on the probability of using those services. On the next slide, I just want to talk briefly about the Choosing Wisely campaign. If you haven't heard about it, it's an initiative of the American Board of Internal Medicine Foundation, and it aims to promote conversations between clinicians and patients by helping patients choose care that is supported by evidence, not duplicative of other tests or procedures that people may have already received, free from harm and truly necessary. And I want to give you just a couple of examples of, on the next slide, of the kinds of recommendations that you would see in the Choosing Wisely campaign. And I'm just going to talk about low back pain, even though our study focuses on 5 different low-valued services plus the cancer screenings. I just want to focus on low back pain just to make the point. There are 12 recommendations in the Choosing Wisely campaign on low back pain. And I just pulled out 3 for you to see. The one from the North American Spine Society states that we don't recommend advanced imaging, for example, MRIs of the spine within the first 6 weeks in patients with nonspecific acute low back pain in the absence of red flags. Basically, the recommendation from the American Academy of Family Physicians is the same. They don't do imaging within the first 6 weeks unless there are red flags. And the American College of Physicians also has a recommendation to not obtain imaging studies in patients with nonspecific low back pain. That doesn't mean you should never get imaging within 6 weeks of the onset of low back pain. These recommendations are that you should wait 6 weeks. In most cases, you should wait 6 weeks in the absence of red flags and just rest and use medication and see if the low back pain goes away on its own. On the next slide, I want to go through our findings. And there's a lot going on here, so let me walk you through this from left to right. First, the 2 bars all the way to the left are for low back pain. And what we find is that among people who have met their deductible, they're 8% more likely to get imaging for low back pain within the first 6 weeks. And it's statistically significant, which means it's a highly credible number. Generally what we're finding is that people who reach their deductible are more likely to get care they probably don't need. And you can see there's this big difference between the first 6 weeks and the first 120 days. So just going out a little bit further, the likelihood of getting imaging for low back pain within the first 160 days, so what's that, another 2 weeks after the first 6 weeks, goes up from 8% to 28% among people who have reached their deductible. No cost sharing or very little cost sharing once you reach your deductible. We find the same pattern for imaging for uncomplicated headache. Within the first 6 weeks, people who have reached their deductible are 41% more likely to get imaging for an uncomplicated headache. When it comes to testing before a low-risk surgery, again, we looked at hernia repair specifically. We found that if you reached your deductible, you were 28% more likely to get baseline labs before receiving the surgery, and 73% more likely to get a chest x-ray before receiving the surgery if you reached your deductible. These are services that are considered low-valued services. And then when it comes to certain testing, vitamin D testing, if you've reached your deductible, 68% more likely to get vitamin D tested and 21% more likely to get PSA testing. So across the board, all these services that we looked at, we find that if you reach your deductible, you're more likely to get services that are considered low value and in some cases may even be potentially harmful. Next slide, please. What I'd like to show you now is our findings related to cancer screenings after meeting deductibles. And here, it's a little different for these services than for the services on the prior page because these services are considered high value for people of certain ages and low value for people of other ages. Right? The recommended screenings for women to get screened for breast cancer is at age 40. And what we find is that once women reach age 40, if they've reached their deductible, they're 11% more likely to get mammography. If they're below age 40, where it's not recommended, though there may be a reason to get the screening, 16% more likely to get it if you've reached your deductible. And while these screenings are typically free, there's no cost sharing even before the deductible, and that's true for all three that you're seeing here. I think one of the reasons why we're seeing, what appears to be the deductible having an effect is because, one, people may not know that they're free, even after all these years. And two, people may wait just because they may be unsure if the service is going to be free. What if something is found and that's going to cost me some money? So maybe I should just wait until after I've reached my deductible to get this service, because if something's found, it will cost less money. You see the same pattern for cervical cancer screening, though, that 33% for women under age 21 is not statistically significant. There's no stars there. It means the number, even though it's 33%, is no different than zero. And I think the reason why it's not statistically significant is there are very, very, very few women under age 21 who get cervical cancer screening. So we just don't have a large sample there. And that's probably a good thing. Colorectal cancer screening, you see the numbers are much higher. For people ages 50 and older, 60% higher likelihood of getting colorectal cancer screening once you've reached your deductible, and 126% higher among people under age 50, where the recommendation for many years was under age 50, and I think it just changed or is in the process of changing to age 45. So basically, again, across the board, for people who reach their deductible, more likely to get these services that are considered low value and potentially harmful. Next slide, please. So some key takeaways for you, some action items. Reaching deductibles results in an increase in use of healthcare services that are unneeded and potentially harmful. You've heard me say that a number of times already. I think it can't be said often enough. Employers, one of the things you can do is very cost sharing above deductibles to reduce use of low valued services. It gets complicated, but what you really need to think about is making I describe it as making your health benefits more sophisticated and more strategic. Others may think it just gets more complicated if you've got all kinds of different cost sharing levels, and that's true, but it's something that you do have to consider as we get more and more evidence of what works and what doesn't when it comes to driving patient behavior. And think about the role of the deductible. In some cases, we think about the deductible as a crude instrument in controlling costs. And we know that in non-HSA plans, you can pretty much exclude anything you want from deductibles, create whatever incentives you want. In an HSA plan, your hands are tied to a degree. And we did see 2 summers ago that the IRS allowed more preventive services tied to the treatment of disease to be excluded from deductibles. And that's because there was evidence that doing things like excluding insulin from deductibles was good for people with diabetes, and excluding low blood pressure monitor for people with high blood pressure was probably a good thing to be doing for people with high blood pressure. So one of the things you may want to do is think about the role of the deductible. Next slide, please. You may remember this from a couple of years ago, this headline: high deductible health plans fall from grace in employer-based coverage. And I think there were a number of reasons why people may get this idea. I'm not quite there yet. I never loved the headline, but I want to show you why, what drove this headline. And you'll see it on the next slide, another slide with lots of data. But basically what it shows is that in a survey of large employers that's been conducted every year going back to 2010, the percentage of those employers offering only a high deductible health plan has fallen. Hey, employers have not backed away from high deductibles like the prior slide would seem to indicate. But what they've done is they've reintroduced more choices. So this orangish middle part of the bar represents the percentage of employers offering a high deductible health plan, or consumer-driven health plan in this case, as an option. And you could see that since 2017, the percentage offering it as an option has increased. The percentage offering it as the only option, that is the blue portion at the bottom, has fallen. It reached a high of 39% in 2018, and has fallen to 22%. The expectation is it'll be 22% next year. You don't see employers abandoning high deductibles. And you can see that in the top there, the reddish part of the bar, where we're almost at a record low in terms of the percentage of large employers not offering a high deductible option. So employers, they're still all in on high deductibles. I think what they want to do, and what you really should be considering if you're offering a high deductible, is how do you make that plan better? Right? How do you offset some of the negative effects of the high deductible? Next slide, please. And I think one of the reasons why you have to, and again, a very busy slide, but let me boil this down for you. If you look at the bottom line, we've basically reproved the 20-80 rule, the 80-20 rule, that 20% of the population account for 80% of the spending. It's not quite 80-20, it's 84-20, but close enough to say that the 80-20 rule still exists. Go up one line where it's highlighted red. What we found in 2017 was that 10% of the population, so half of the 20%, 10% account for 70% of the healthcare spend. And when you look at these people, what you find is that their average spend is $41,000. But I think more important, we know they're high spenders, right? They account for 70% of healthcare. But I think the most important finding here is that their minimum spend per person is $12,000. There wasn't one person in this population that accounts for 70% of the healthcare that used less than $12,000. Deductibles don't do much to control the healthcare spending of this group. These are people, all these people are going to blow through their deductible, and they're probably going to blow through it early in the year. Not only are they reaching their deductible, but 50 to 60% reach their out-of-pocket maximum. So, you know, it raises the question of what impact are deductibles going to have on the bulk of the spending. And, you know, what we found with this study is that, you know, to some degree, they encourage use of healthcare services once people reach their deductible. And for, most of the spending, 70% is going to be, you know, people that have reached their deductible. And finally, I do want to leave over a few minutes for questions. But if we go to the last slide, I do want to point out we've learned a lot about deductibles over the last 10 years. There's you know what a friend of mine coined as the dark side of high deductible health plans, but I don't want to leave you with just the dark side. So we've got Luke Skywalker in there as well. But just a few things to note. You know, we've been talking about low valued services for the past 20 minutes. What some of the other things we've found when it comes to deductibles: lower medication adherence among people with hypertension, dyslipidemia, and diabetes. No employer wants to see their diabetics stop taking their medicine, right? So what do you do to address that? We have found higher emergency department visits among people with high deductible health plans, especially among the lower income. And what we think is happening there is that as people move to high deductibles and they have chronic conditions, they stop taking their medications. It causes complications, and they wind up in the emergency room. And about half of them get admitted to the hospital, which means they really do have some serious issues going on. The good news there is that, and this gets down to the, you know, some of the dark side effects are temporary at the bottom of the page. The good news there is we see some of these effects disappear after 1 or 2 years. So people do, you know, unfortunately, they learn their lesson the hard way, but they do come around and they start getting the care that they should be getting. We found higher inpatient admissions among the lower income, lower use of flu vaccines among the lower income. Nobody wants to see lower income people not getting flu vaccinations. And again, this is one of those services that's free. It's outside the deductible. And as are breast cancer, cervical cancer, and colorectal cancer screenings. And I think what employers really need to do is a better job of educating their people about what's covered under the health plan and how it's covered. We have found that diabetics are less likely to get LDL testing, but it's not all bad news. And I don't want you to walk away thinking it's all bad news. We didn't find any impact of high deductibles on various vaccinations and HbA1c testing for diabetics. No impact. Deductibles had no impact on specialty medications, those very, very, very expensive medications for people with conditions like multiple sclerosis and rheumatoid arthritis. And I'm not surprised by that because it only takes one drug fill for one of those medications to use up your deductible. And no impact on medication here for people with asthma, COPD, or depression. Thank you so much for your interest in the presentation today. Happy to answer any questions, Marianne, if there are any.
Yes, we do have a question. Thank you very much, Paula. This is, wow, this is really solid information. I have one question that came in from one of our attendees, and then I have one if there's time. So this is from Luke Pretal. He says, I see the correlation between those who overuse after deductible, but not causation. Could it be that those who reach the deductible tend to be the people who have the chronic and or complex conditions, which would drive some of these actions?
Yeah, that's a really good question. So, in the limited time that I have, I didn't, feel I had the time to go through the modeling that we did, the regression analyses, and so we've gone beyond just looking at correlations to look at causation, and we think there is causation here. And I would note that we do control for health status in these models. So it isn't just because it is people with chronic conditions that are driving some of the use. We're even seeing it for things like vitamin D testing. So, I don't know if people with chronic conditions are more likely to get tested for vitamin D. I don't think that's necessarily the case. And there's lots of low-valued services out there. We focused on just a very small segment of them to make this as manageable as possible. And I think if we, looked at others, we'd find similar patterns.
Mm-hmm. One of the questions I had when I was listening is that I wonder how much, and I don't know if you can tell this, how much is due to patient demand? For example, we did studies on low back pain with several physician groups, multi-specialty and spine or orthopedic surgeons, spine experts, and on low back pain specifically, uncomplicated low back pain a couple of years ago. And what was interesting is that it seemed like the specialists were more inclined to do more MRIs and more, treatment, perhaps even surgery before going to the less invasive, for example, physical therapy, starting with that. So part of the situation might be that this is their protocol and it may not be the standard care pathways. But on the other hand, how does a doctor, if there's patient demand, how does the doctor know whether that person has met their deductible? I don't know that anyone's ever asked me if I've met my deductible before they start ordering tests.
Right. I think that's a good point. I don't think the physician is engaged at that level. But I see the conversation kind of going this way. You show up at the doctor's office, you have low back pain. Doctor, I think you need an MRI. Doctor says, well, it's not really indicated. But if it's something you really want to do, then we could go ahead and do that. And the patient, then makes the decision based upon how much it's going to cost them, right? They know themselves. And they know that if they've reached their deductible, it's not going to cost them a whole lot of money. If they haven't reached their deductible, it's going to cost them a lot.
Yeah, interesting. I didn't see any other questions that have come in from any of our participants. If there are any, this is your last chance to ask Paul. He's got a hard stop at 1 o'clock. So you've got 3 minutes. But in the meantime, I'm thinking that for employers, there are multiple things that they can do, like you suggested, varying the deductible after a certain point. And the other thing is educating employees about how to determine, how to research something before they just accept whatever the treatment plan might be, whether it's high value, includes high value or low value. I think that's part of it, and engaging employees in going ahead and understanding what is not included in the deductible, the cancer screenings, for example, the flu vaccines, and some of the other things that they may not realize at all, like you said, maybe not included as part of the deductible. They wouldn't have to pay. So
I think, we don't know everything, right? We don't know what all the recommendations are, all the things we should be thinking about when it comes to deductibles, but this is the kind of conversation we need to be having,
yeah,
right? We need to start brainstorming about, what's the right You know, what's the right incentives? Where should those incentives be?
Mm-hmm. Another question did just come in, and it's is there a correlation on second opinions and low or high deductibles? We know that second opinions can have amazing impacts on cancer care, for example. So that sounds like a real educational process too.
Yeah, that's not something we've looked at because we're just looking at straight claims data. But I think that is worth looking at because you know, engaging, you know, patients aren't the experts, and experts don't always agree. So the degree that we're having these conversations to figure out what the right course of care is, I think is what we should be doing.
True, and a lot of employers are starting to mandate second opinions for a cancer care diagnosis because we read some of the data I've read is that about 80% of the first initial diagnoses, which is often in the family practice or primary care setting, may be incorrect. So with that, I think I want to let you go, Paul. I sure appreciate your being part of this discussion. What an interesting presentation, what interesting research you're doing. I think we've opened up a whole lot of areas of research for you to continue on at EBRI because this is highly valuable to all of us out here in the hinterlands, the employer world. So thank you again.
Thanks again so much.
Yes.
Really appreciate being here.
Yes, and stay safe, stay healthy, and happy holidays.
You too.
Thank you. Okay, so now what we'll do, we'll immediately turn the discussion over to Gary Strelke, whom I introduced earlier. There he is, picture there, but you also see him on candid camera here, I hope. Gary, you are practicing what we were just preaching, and I think we're very interested in seeing your presentation, hearing your real life experience, boots on the ground with employees at Steelcase.
Great. Well, thank you for having me. Paul was speaking my language as the Wellbeing Navigator at Steelcase, and I think a really well thought out well-being program that's really well executed, whether you're calling it well-being or wellness, can actually help to save the company a lot of heartache and money and some of these low value services that we talked about through things like education and consumerism and providing appropriate resources. So we're going to talk about that today. So I am the Wellbeing Navigator. I love the title. It's incredibly generic, and I think that Steelcase has done that intentionally so that anything that nobody else wants to touch can get lumped under me as the navigator. Next slide, please. So who is Steelcase? We are the largest office furniture manufacturer in the world, and I would say that we create and sell office space primarily. Think about in a world post-COVID-19 when a lot of employees are not returning to the office. You can think about some of the potential stress that we might be experiencing in an industry where we are supporting office space, but we've got approximately 80 locations worldwide, around probably closer to 12,000 employees now. Key business centers, Mexico, Malaysia, Romania. We also have work-life centers everywhere, and I get to support all employees from all areas. So that's really exciting. I know that our conversation today is primarily focused on US-based companies, and so we'll be focusing on that as well. So we've done this huge paradigm shift. We've to this point talked a lot about this concept of return on investment. In other words, our employees engaging in things, products, services, testing possibly, doctor's visits that are actually bringing a return to the company. Are we saving money essentially by offering things to our employees? I know second opinions came up as a possibility for that. And we really started to shift. Go ahead and progress this slide. Perfect. We've really shifted from return on investment toward value of investment. And our goal here is if we're going to have an employee well-being program, our goal is to get employees to actually engage in many of the services that we offer in our employee well-being program. So we're kind of shifting from policies and programs to people and peers, from information to inspiration. And you can kind of read through down that list. But the goal is to create a well-being program that thinks about the actual end user and provides them with things that they are engaged in, that they want to seek. In other words, if they were out on the street purchasing services for themselves, what would they be likely to engage in? What would they be likely to purchase? What would that service look like? And so that's been a big focus of ours. Next slide, please. The way that we define employee well-being is really broad, and we look at it kind of in this way. This is a diagram that we created probably maybe 6+ years ago with a company called IDEO. And we put the employee at the center, right there where it says my job. And the things that influence and affect our employees' well-being are really their aspirations, their passions, and their situations. And aspirations, think about anything that you might aspire to. You know, what do I want to do? Do I want to retire at a certain age, et cetera? And so a lot of our well-being opportunities are designed to help people have a better understanding of, you know, what would it take to build my 401k so that I can retire early? What is my value or quality of life going to be like after retirement? Passions are really important. So we build a lot into the workplace environment that creates an opportunity for employees to participate in their passions, which helps them to stay healthy or well. But more important for our conversation today is this segment around situation. So what this means is an employee can be plugging along in life, everything is going really well for them, and they enter into some level of adversity. So back to Paul's conversation, when we talk about healthcare, for example, they get a chronic care diagnosis, they get an assessment or a test that says something that maybe throws them off. For this conversation, it could even be a mental health condition. It could be a life crisis like grief and loss. It could be something else. In fact, if I surveyed every person that's attending this workshop today, everybody would probably have a really different definition that's personalized to them around well-being. And the situation is really driving or dictating what that definition might look like. So for me, if I'm in the throes of mental health, maybe I've got a diagnosis or I've experienced some trauma that has led to mental health signs or symptoms, my well-being definition is probably going to revolve around finding mental health care. If I'm somebody who's very overweight and maybe I'm pre-diabetic, my definition of well-being might be really focused instead on pre-diabetes or changing my nutrition or exercise behaviors. And so what we want to do is we want to recognize that not all of our people, not all of our employees are in the same place. They don't all define well-being exactly the same way. So how do we go about identifying where people are at and how we can help them? Next slide, please. So we did a little study within Steelcase, within our own population, just to kind of identify what's really going on. Go ahead and progress the slide. So we started with the employee. And what we found is employees who are engaging in well-being are coming to us with a variety of signs or symptoms. And I like to call these downstream signs or symptoms. So they're coming to us with exhaustion, maybe some acute illness, stress, sadness, maybe their performance is suffering in some way. They're not able to get their work done. They've got irritation, fear. But those, again, are really just symptoms. And symptoms don't tell us a great deal. I think one of the examples that I was thinking of while Paul was talking was we would have somebody that, I just had this probably 4 weeks ago as I was sitting in our Wellbeing Hub. We had an employee that walked down and they had a swollen ankle. Over the weekend, they were playing basketball. Their ankle was swollen a little bit. But I noticed they were able to put weight on it. They could walk down to actually see me. And so they've got this acute illness. They've got this pain in their ankle. Now we're not necessarily sure what the injury might be. If there really is injury, it's probably likely a strain or a sprain or something like that. But what would they do if they didn't come down to the Wellbeing Hub? One of the questions that we like to ask is, what are you going to do? And for many employees, they might go to an emergency room, they might go visit with their doctor, they might take medications, whatever that might be. But that's just a symptom. I've got ankle pain. And the employee, they don't know what they don't know. They don't necessarily know what the ankle pain is all about. So if we look at one step above this, we look at things like, what are the underlying issues? Mental illness, addiction, abuse. Maybe there's some recent significant change. We are all experiencing right now this global pandemic. And so a lot of us are in the throes of change. And when you think about a global pandemic or even things like social justice, as we go through some of the social justice difficulties that we're experiencing right now as a nation, what we're finding is there's a lot of downstream things that are happening. So it might be a pandemic, but what's going on in the house? We've got increased levels right now of things like divorce, domestic violence, financial struggles, suicide, suicidal ideations. And as an employer, you have to see these things coming. You have to recognize that post-COVID-19, there's going to be an increase. Now, the big question is, where are people going to get help for these things, and what kind of help are they getting? So back to my example of this rolled ankle, this employee could go to an emergency room and burn through their deductible really quickly every time they get a roll, they roll their ankle and have a sprain. What was cool about them stopping down to the Wellbeing Hub was I could assess and evaluate for some of the signs and symptoms of illness and identify pretty quickly that it was likely they had a swollen ankle because they rolled their ankle playing basketball over the weekend, and encourage them through some healthcare consumerism to give it a little bit of time, 72 hours, maybe a week, to see what happens next. And then educate them on, here are some things that you can look for that might be indicators that it's probably time to go to the doctor. And here's the kind of healthcare facility or service you should engage in for something like this to keep the costs relatively low. And in other words, urgent care versus emergency room, etc. But what we're looking at here is there's this difference between symptoms and then the causation or the actual issue. Oftentimes we get caught up as employees or in employee wellness around the symptoms, and we don't think about the bigger cause or the bigger issue. Next slide, please. So what we do with this information is we start to evaluate, all right, if it's an issue, how should we handle the issue? Or if it's a symptom, how should we handle that? And issues, what we really thought about doing here at Steelcase is thinking about assessing issues, identifying what is the issue, and then managing or resolving these things. So if the issue is employee stress, we should assess the stress. It could be that it's stress related to some kind of a situation. It could be that's more systemic in nature. In other words, everybody is probably a little bit more stressed out right now because of COVID-19. That's important to recognize and understand. Or it could be the development of the beginning stages of something like a mental illness, which might lead to management in a little bit different way. There might be other referrals or resources or assistance that we might be able to offer or provide the employee that could help them manage those things in a little bit different way. And then we look at the symptoms. The symptoms should really be managed, and coping strategies should be developed and implemented to decrease personal and organizational impact. As we were talking about, this idea of low value services earlier, there is a cost to the employee until the deductible has been met, and then there's a cost to the company. If we can help to manage some of these symptoms so that it doesn't progress to be very costly, and there's a couple of ways that we look at costs. Sure, we look at healthcare costs directly associated with engaging in a healthcare system, but we also look at costs to the company in terms of absenteeism or presenteeism. We look at productivity as it relates to maybe an employee who is has some level of dysfunction and they're not able to complete their job in a way that they might if they were without that dysfunction. Typically what we're seeing for presenting symptoms, in other words, these are the things that employees are aware of, they know are going on. People are stressed. We've found increased levels of sadness, anxiety, exhaustion, fear. And there's a nice long list of some of the things that people are identifying. And oftentimes it's what they feel is the first thing that comes to their mind, and they don't necessarily know why they feel this way. So naturally, what are they going to do? They're probably going to engage with some level of professional service, whether it's their doctor or a psychologist or something. Many of these things can be costly, time-consuming. In some cases, they're very necessary. In other cases, they're maybe not as necessary. So as a company, how can we help employees to become better at understanding the situation or state that they're in, better at consuming health care in general, whether it's physical health or mental and emotional health, so that ultimately we know that they're on the best treatment protocol or plan, and the company itself is reducing costs and expenses associated or low productivity associated with some of these conditions. Next slide, please. So if I were to define how Steelcase is approaching this whole process, there's really three categories that we're looking at for a goal for our employee well-being program. The first category is prevention. When you think about prevention, think about preventing chronic disease, preventing injury. Those health and safety partnerships or relationships are incredibly important, creating ergonomically healthy environments, safe environments in our manufacturing population, et cetera. But also we should think about things like preventing life adversity. When I say that, I mean suicidal ideations. One of the services that we offer at Steelcase is mental health first aid. We try to get as many employees certified as mental health first aiders as we can so that they can pay attention to the well-being of their coworkers. And when they start to see signs and symptoms of mental illness developing, they're able to make referrals for that employee. A, help the employee recognize that mental illness might be developing, and then B, help to refer them into an appropriate level of service or encourage them to go and see a healthcare professional, whether it's our EAP or a Vita coach or some other level of service that we have a partnership with. So prevention, we want to prevent diabetes, we want to prevent chronic heart disease, we want to prevent suicide, but we also want to leverage some of our vendors and services to prevent burnout from stress or other life adversity like divorce and bankruptcy. We leverage financial institutions. The next phase here is this concept of support. Once an employee is experiencing some kind of adversity, or they're in the throes of difficulty, whether it's, again, chronic conditions or mental illness, how can we as an organization support them with the appropriate level of support? So if they have diabetes, can our on-site nurse help to ensure that they are getting regular blood sugar assessments? If they have diabetes, can they get on a weight loss program or an exercise program that might support them? How can we refer them into something that is going to make their experience a little bit easier and possibly prevent them from getting worse? So that's the support category. Some of the other things that we might look at supporting them with would be through difficult seasons of life. So if they have a close loved one pass away, for example, if they're in the midst of financial bankruptcy, again, my role and the role of the team that I work with is to help people to identify through self-reflection what's going on and what can we do about it. And in many cases, Steelcase has opportunities to help support with some of these things. And then finally, recover. Once an employee goes through an experience, again, life adversity, maybe it's trauma, maybe it's addiction or something like that, how can we step in and support them so that they can recover quickly and get back to a pre-level functioning that maybe they were functioning before they entered into this difficult season or time? So again, many of our resources and vendors and the way that we think about well-being is designed to help people with recovery. So when we look at those three buckets, prevention, support, and recovery, what we are doing is we are helping our employees, regardless of the season that they're in or how they define well-being, to engage in services to improve how they consume, I would say, general well-being related services, mental, physical, you could say social, financial, et cetera, et cetera. And ultimately what we'd like to do is create a healthier workforce. Next slide, please. So this takes a team, this takes a network, and this is just an image that kind of gives you an example of all of the people and services that are really involved in this. You can see Encompass up there is our employee assistance program that we've had a very strong partnership with them where they bring things on site like elder care support services and grief and loss support services, but they're a phone number away to a virtual visit with a healthcare professional, master's level social workers who can help with a variety of life challenges. Best doctors, we mentioned second opinions and referral services. We want to make sure that when somebody is experiencing a healthcare condition, they are getting the appropriate level of healthcare service. We don't want them having a knee replacement surgery if that's not something that is necessary based on the condition that they have. We want to ensure that they have the best possible outcomes. And oftentimes, Paul had mentioned it earlier, and I took a note of it, that some of these services, these low value services, can actually be harmful. And I can tell you several examples of individuals that had knee replacement surgeries that actually had worse outcomes than had they left the knee alone. Vita is another really great example. And I love that Craig at the very beginning of this segment talked about value-based care, which fits so nicely with our value of investment. having access to a coach that can help somebody regardless of what level they're at, prevent, support, or recover to help them improve some of these conditions and their overall general well-being. And of course, massage, we do massage like crazy at Steelcase, which really helps musculoskeletal conditions. Next slide, please. And let's go ahead and progress this slide all the way until all the images are demonstrated. So here's the model that we use. And really it puts the employee at the center of the model. So that figure, that silhouette in the very middle, think about that as the employee. The little guy pointing there, you could say that's me, that's your company's well-being navigator. Maybe it's an HR professional, it could be a health and safety person, or at times it might even be a leader in the organization. And then that little toolbox there, all of those images and services and vendors that I talked about earlier, that's what's in that toolbox. So our goal is to meet the employee where they're at, and you could really start here with personal reflection. Personal reflection means that employee walks in, they've got a soreness in their ankle, we can ask them questions, what did you do, what are some of the other symptoms that you might be experiencing, and then share. So from that personal reflection, hey, I was playing basketball, I rolled my ankle, then what we can do is share some insights. Hey, here are the things, here are the potential things that this could be, and here are some ways that you can engage with the healthcare system to ensure that you're getting the best possible treatment protocol. So that leads to that personal insights. Those personal insights, that's valuable information, it's useful, and it helps to guide them in their next steps. This hopefully will lead to a change in behavior. In this case, the change in behavior might be, hey, I'm not going to the emergency room. Instead, I'm gonna rest, I'm gonna raise or elevate my ankle, maybe try some ice or some ibuprofen at home, see how things go, and then ultimately our goal is to improve well-being. Now you can insert anything in this model, whether it's somebody who's experiencing high blood pressure or high glucose, it could be somebody that's just overweight or has low fitness levels, maybe they've got low energy, and then at any point in time, they're meeting with the Steelcase representative who can engage in these conversations, or referring them to a coach who can engage in these conversations and progress them through this process. So maybe the first time they go through this, it's related to being overweight, high body mass index, which we know sets them up for the likelihood of chronic illness. We help them personally reflect, whether it's me or one of these vendors and resources, again, moving them through until they get to improved well-being. After they manage the first condition, maybe they can start to manage something else, like their financial well-being or their social well-being, or maybe some relationship issues that they're having. So that's the model that we approach this with. Go ahead and move to the next slide, please. I love this case study. This is a case study that was that just kind of demonstrates how this might work with an employee who utilized Vita. This is a male, 57 years old. The health condition here is obesity. Again, we know obesity can be incredibly costly depending on if it leads to chronic illness or not. So helping this gentleman to lose weight and get a better grasp on the body mass index would be incredibly valuable to him, but also the company. So enter a weight loss program. This is the program that this gentleman was involved in. And go ahead and flip to the next slide, please. Vita, again, has been a tremendous partner as we look at those three categories of prevent, support, and recover. Our employees have access to a Vita coach. Through a simple referral, they can meet with a Vita coach, and you can see down here on the bottom of this slide, 93 consults completed, 759 messages sent. Those messages are on a variety of things. Maybe some of them are, hey, dealing with challenges around nutrition. Maybe some of them are related to stress. You can see 54 lessons and tools. We now have a better educated employee. 2,856 completed food logs, which gives us an indication that this employee is taking this process seriously and managing and monitoring their nutritional habits. 4,804 manual metrics logged, which is just tremendous. And after about a year, there's a 24% reduction in weight loss, so 80-pound weight loss. Now, as this employee has a better grasp on their physical health conditions, as they've lost weight, better BMI, lower risk for diabetes, lower risk for heart disease, now they can start to shift maybe their focus onto something else, their financial well-being, for example, their relationship well-being. Again, that's just one really simple example of how we can leverage one of our vendors in a way to support the well-being of our employees, which ultimately is going to benefit the company in a lot of ways. And then our last slide, please. All right, so I know that I threw a lot of information at this group in a relatively short period of time. I could speak for days on the nuances of how we function in a well-being program at Steelcase, and happy to have conversations with anybody that's interested in listening. All right, so hopefully you found some of this information useful, and I'm happy to take any questions that anybody might have related to.
Gary, you have a very comprehensive program, and I don't have any questions in the chat box. Oh, wait a second, one did come up. I've got a few myself, so let's see. A question here is from Amanda Rudd. She's with Motion Connection. She's asked, well, that's very interesting, which I agree. What is your overall percentage of engagement or participation in these different programs?
That is a fantastic question, and I wish that I could answer it in a more comprehensive way, but I'll give you this. So typical engagement rate for an employee assistance program in the US, I would say we're doing really well if we're at 6.9%. And I'm just picking out that one vendor because that question has to be answered for each individual vendors. But our EAP engagement at Steelcase, on average, we do track it quarterly, is between 18 and 30. It's been as high as 36%. So well above the average. The reason for that is, again, how we deliver this service. We're encouraging our leaders, we're encouraging our HR professionals to make referrals into the EAP. Beyond that, we're encouraging our EAP to come on site, to create messaging that is appropriate for our employees. In other words, when you engage with our grief and loss program, you don't necessarily even know that it's the EAP that's delivering that service. You just know that we have a grief and loss program that's available to you in the Wellbeing Hub or virtually, and so you're engaging that service, not even necessarily knowing that it's part of the EAP. Now, something else that we don't do is we don't force all of our employees to engage in the same services. We make them available to employees, but we recognize and understand that every employee is in a different season. So in one season, as one employee, I might need some weight loss coaching, but that doesn't mean that everybody in our company needs weight loss coaching. Another employee might need smoking cessation coaching, but again, we don't want to force all of our employees to do that. A really good example of that is our biometrics. We offer biometrics to employees, and we get a good number of employees that engage in biometrics. But we know that not all employees need this service because many of them are already getting it from their doctor, or they just don't need it, right? Low value. They're young, they're healthy, they've never showed any signs and symptoms. 2 years ago when they did meet with their doctor, when they were 22 years old, the doctor says, hey, you're healthy, I'll see you back in 5 years. There's no point in poking their finger every year. Other things like flu shots, of course, we're going to encourage as many people to get a flu shot as we can to try to develop that herd mentality. Hopefully that gives you some helpful answer, but to answer that question, I'd have to go through each vendor.
Sounds like you got the right answers there. One of the things I wanted to ask you is, you're dealing with several really interesting, we'll call them service providers, offering different types of programs. And the one slide you showed were all the different services that you're offering your employees. A couple of questions. One, how do you decide what services to bring to your employees? Do you do some sort of a data analysis or population analysis of, all right, these people need obesity, consulting, these people need this, or mental health or whatever? How do you do that?
Yep, so a couple of ways. One, we do survey our population. In the 6 years that I've been with Steelcase, we've done a couple of surveys. What we want to do is find out what our employees are interested in. So there's it's the crossroads of where our needs and our wants intersect. That's how we determine or dictate the services that we bring to employees. And the other piece is called fail fast. This is something that I learned when I came to Steelcase. Is I would rather engage with a service, give it a try, pilot it for 3 months, see how it goes, see who's engaged. If nobody's engaged, maybe we make an adjustment because they didn't understand the service or didn't understand how to engage. Try it another 3 months. And if it fails, if nobody uses it, we tried this with a nutrition service a number of years ago, and it literally failed fast. We gave it a good solid 6 months and people just determined we weren't interested. And so we moved on to something else. So the services that we're providing right now, our massage service has been fantastic. We do active release therapy with our employees. We've seen that employees that engage in our total well-being program are something like 93%, between 89 and 93% less likely to seek further medical help. So if they get a clinical massage, or they meet with our paramedic or our nurse, or they meet with our registered dietitian, they're not going to their doctor. So we're able to handle everything in-house, which means we've got fewer OSHA recordables, et cetera.
Mm-hmm. Well, it sounds like the Steelcase is very, very fortunate to have its own in-house navigator, which you seem to be, and I love your very systematic approach to handling it. I loved seeing the causes and the issues and then the symptoms, differentiating between those two. That was really, really helpful. That was a great chart. I'm going to hang on to that one. That's pretty good. And I suppose that with a lot of the mental health issues or substance abuse or other challenges, anxiety, stress, and so on, you have a strong EAP, which probably is another third party. Is that correct?
Absolutely. Yep.
Okay.
EAP and VITA together, and we've got a couple of other services that can touch on that, are a little bit more local in the regions that we're in, have been fantastic partners.
Okay, right. Okay, well, this has been a very, very informative presentation, and as I said, I love seeing how organized you are in approaching, you know, the well-being for your employees. And I have to say, no wonder Steelcase was named among the world's most admired companies by Fortune magazine in 2020. Yes, and congratulations for all the work you did to make it so. So anyway, thank you again, Gary, very much for your presentation, being part of our first session of this year's forum. I'm sorry that Paul Bronstein isn't able to stay for this part of it, but we'll be switching over to the next session in 5 minutes. We'll get started on that. So y'all can run, get a cup of coffee or a glass of water, and come on back, and we'll be ready to roll in 5 minutes. Thank you.